First, there was the collapse, and then the darkness. Now that morning, it started like any other work day for 33 miners in Chile, but a collapse resulted in them being trapped in a room not much larger than I'm standing here on the stage. And over the hours that came, that room became darker and darker to the point that if a family member or friend had been even right beside them, they would not have been able to see them. We rallied multinational response urgently to save them. We weren't even sure they were alive. And we knew the first thing we had to do was contact them. We had to engage them. So we dug a hole 4 inches in diameter, and we drilled it thousands of feet down, and we made contact. And we found out that they were still alive. This took days before we made this connection. And then secondly, we began providing them support. Food, water, and connection and engagement continued as we provided support. We did all that for weeks and weeks while we created the pathway to rescue every last one of them. Now, it's easy for us to think about that for 33 individuals in somewhat of an unusual situation. How would we do that? Not for 33, but for thousands a day. Well, we do that. We have individuals who are in car crashes, they have heart attacks, and we are Johnny on the spot with ways to contact them through the phone, through the emergency medical system. There are individuals who come to them, and we have places for them to go. Now, we've been involved, our team has been involved in crisis engagement for many years. Over a decade ago, we established the Georgia Crisis and Access Line, which was featured in Business Week at the time for innovation. Since that time, we've developed the Care Traffic Control System and integrated the living room with direct law enforcement drop-off. But in mental health, we don't rescue the minors. One of the most common reactions is that individuals go to jail, but most of the time that's not the case. Most of the time, they go to the hospital. And that's the case in the United States, in the United Kingdom, in Australia. Now, when they go to the hospital, the most common reaction is not the urgent connection that we're talking about, but some combination of delays and detainment and many denials of service. The Seattle Times in 2013, after 10 individuals sued who were just south of the city, they found that the average wait for psychiatric boarding was 3 days. Now, if I queried this audience about your own experiences with EDs for medical, those of you who've been in the ED for more than 3 hours would remember your stories. But imagine 3 days. On the day that a person is experiencing their worst challenges. It's not only a challenge that individuals struggle with, it's a very wasteful and costly approach that runs into the tens and hundreds of millions of dollars as we see this repeated again and again. So many of us got together with the National Action Alliance and we put forth a model called Crisis Now to suggest a different way, to suggest a way that would be more akin to our approach to those minors, to the approach we take every day for people in medical emergencies, where crisis services designed for the person in crisis are available anytime, anywhere, for anyone. And we released that document, and we began to think through, well, how could we repeat that same approach, where we make a connection, we provide support, and we do a rescue. So let's talk about those 3 steps. The first thing we have in our Crisis Now model, and Anita Everett was the first one I heard put it this way, sometimes you have to have someone to talk to. I'd been in Arizona for a short period of time, and my youngest son let out a blood-curdling scream. I ran to him, and he had been bitten by a scorpion. Now, I was new to Arizona, hadn't received the orientation. This was a very scary event. So within a minute or two, my wife and I were on the phone with a helpful person from poison control. And she said, "Oh my goodness, that really hurts, doesn't it?" And I'm panicking, but there's got to be something we can do. And she said, "Well, you could give him an aspirin, ibuprofen, or something like that." And I said, "You're just giving me something to do." And she said, "You asked for something to do." It wasn't a pleasant experience for either me or my youngest son, but we got what we needed with that telephonic support. We didn't go anywhere, and no one came to us, but we got on a path that led to where we needed to be. It was just that brief telephonic connection. But sometimes that's not enough. Sometimes someone needs to come to us. Sometime later, my father, who'd had problems with his heart before, is having unbelievable pain that he was attributing to his chest. And EMS and fire were on the scene in a very quick amount of time, in a few minutes actually. And they talked to him, they did an electrocardiogram, and they found out that in fact it wasn't his heart, but kidney stones that were acting up. And he did have to get medical attention, but not at that time. They remedied the particular situation. And again, we didn't go to the hospital. He had a very significant need, and they responded to that in the moment. Now, we don't have this ready access for people in a psychiatric emergency on their worst day. But sometimes a phone call connection, sometimes support in person, neither one of those are enough. Just a few weeks ago, my oldest son, in the middle of the night, says to my wife that he needs another breathing treatment because he's got asthma. And she gets up and says, "Well, you've already had a breathing treatment. Let me do your pulse oxygen just to see where that's at." And for those of you, how many of you are medical in the room? It was 85%. Yeah, that's what we thought. And so we took him to the hospital, and he was there overnight as he needed a place, and he could have needed to be there longer. They were going to keep him until they got his pulse oxygen up. We do this thousands of times a day. We triage out, and we have an approach that's safe, it's effective, it's standardized, and it's efficient, and it's very humane. And typically, it's accompanied by a very caring and compassionate approach. We do not have that in the behavioral health space. So it seems overwhelming, but let's do the math on it, and let's begin to action plan. Dr. Draper set us on this path, but let's look, and when we do the math, the one thing we usually miss is we look at the high and low, and Dr. Draper referenced that continuum. We don't look in the middle. So let's look in the middle. Most communities are set up like a light switch. They have a limited amount of acute care that we're grappling over, or they have outpatient care. And folks either need the highest or the lowest. But if we use something like the level of care utilization system, much more of a ladder than a light switch with 6 levels, it looks at the criteria of risk of harm and what's going on with the person's functioning. That algorithm spits out one of 6 levels, all the way from 1 to 6, from outpatient and follow-up, all the way up to locked residential. This middle level is the one that we don't attend to. And an 11-year study of the data from the Georgia Crisis and Access Line, thank you, Wendy Farmer, represents that a very significant portion of people actually present in crisis in that middle range. And the crisis that we're talking about here are those, we called it the core community crisis flow. The back of a police car, a hospital emergency department, or community-based mobile crisis. So someone who called a crisis line and found their situation resolved was not included in this data. These are only those individuals who touch our public sector. What does that mean that all of those individuals are in the middle when we build our systems around the light switch approach? Outpatient services that maybe it's hard to get into, and a limited amount of inpatient. We've actually done the math a little bit further, and we believe it's 200 persons, that core community crisis flow, per 100,000 population. In a city the size of Phoenix, that's 8,000 people. Nationwide, it's 600,000 people per month who are hitting our core safety net. But we can stratify them and look at that 82% in the middle and begin to build out key services designed to meet their specific needs. Now, what's the difference when we attend to the 82%? Well, in the Phoenix area, we've done the math because the Access, or the Medicaid Authority in Arizona, is investing in these services, has been for many years, and we've evaluated what happens when you take an approach that's more effective, humane, and inexpensive. Here's the first thing that happens. If you take the individuals who are boarded in an ED, detained and waiting for care, and you back them up and line them up one after the other, instead of them occurring throughout this year, if you line them up one after the other, it's a staggering 45 years of psychiatric boarding that's reduced by the approach that Arizona takes. The second thing that it does is, because you're not doing that boarding, law enforcement is not, what I heard recently from an LA chief, they're not engaged in wall time, where they're leaning against a wall and being borrowed for transportation and security by the hospital staff, which yields, in the Phoenix area alone, this approach yields a savings of 37 full-time equivalent law enforcement officers, which means they're performing public safety as opposed to working with individuals with mental health. We're just beginning to quantify the impact on fire and EMS, but there's a savings there as well. These law enforcement officers instead are doing the job that they're trained to do out in the community. What about the fit, the alignment of the locus assessment that we did clinically and the service we connect someone to? When you take this approach, the individual's 6 times more likely to receive a service that links to the level of care we said they needed. Crisis clinical fit to need is what we call it. We have a tool on the crisisnow.com website that you in your community can begin to put in the numbers of the resources you have. But if you have that light switch approach and you move all the way to a Crisis Now approach, you're likely to yield a 50% savings in your overall healthcare spend. So calculate your own. Look, if we can do this in Arizona, you can do it too. We started in our living room facility, the crisis facility that RI operates in Arizona. And back in 2014, we said, look, we're going to follow the lead of Margie Balfour, who's here in the front, at Connections Health Solutions, and we're going to adopt the direct law enforcement drop-off model, which means we're never going to reject law enforcement. We're going to accept them without them going to a hospital ED for medical clearance first, and we're going to turn that over in a 3 to 5 minute time frame. They're going to be back on the street, engaged in public safety. This is them in their law enforcement parking space, going to the law enforcement door. They enter the door on the right. They're met by a peer, our nurse practitioner or physician staff, and they go through that door on the left directly into the program, a special transfer unit so that law enforcement can be in and back out on the street. And it incentivizes them to come. Now, we've been one of the most innovative programs in the country before that time, but we didn't accept every law enforcement referral. We accepted many, more than some whole states are doing right now, but not all of them. And in late 2014, we said, we're going to accept every one. Since that time, we've received more than 20,000 consecutive guests from the back of a law enforcement car and taken every single last one of them. That's the Crisis Now approach. Now, in Arizona, we had a single payer platform for many years, but starting about 5 years ago, we began moving into the landscape today. Again, if we can do it in Arizona, you can do it in the community that you're in, where we have multiple payers. We had a match on Monday and Tuesday to focus on this. We have a website in a partnership with NASHBA, the National Action Alliance for Suicide Prevention, the National Suicide Prevention Lifeline, the National Council, and others that has these resources, including that calculator that we mentioned. And we have a new feature called Crisis Talk. So if you don't track the Crisis Talk dialogue, we hope that you'll engage and even participate in that conversation. It's time for us to take the approach we took with those minors. Now, more recently, there were some minors. They were minors. They were soccer players in Thailand. and they also got caught in a cave. We rescued every last one of them. In fact, the only one who died was one of the individuals working to save their lives because he ran out of oxygen. It's time for us to prioritize this, and we can do this, and we can succeed. Thank you.